Good afternoon and welcome to Organ Donation and Transplantation in the Time of COVID-19. Dee McGuire with UW Health Transplant. Thank you all for joining today. We have over 125 registrants from 9 states and 2 countries and an excellent lineup of experts from UW Health here today to share valuable information and insights about organ donation and transplant during the COVID-19 pandemic. All attendee audio lines have been muted, and there will be an opportunity to submit questions after the presentations are over. To share more with you, I'll now turn it over to Dr. Dixon Kaufman, Medical Director of the UW Health Transplant Center.
Thank you, Mandy, and thank you all for participating and joining in on this really educational, informative webinar in this very interesting time we find ourselves. I'm Dixon Kaufman, and I'll be helping moderate this. And to do so, I will be introducing each of our speakers before their respective presentations. I will try to be respectful of everyone's time and make it pretty concise and to the point. And I think we should go ahead and jump in right now. Our first speaker is Dr. Nicole Neidlinger. She is an associate professor of surgery in the Division of Transplantation and in our Department of Surgery at the University of Wisconsin. She is also the associate medical director of the Organ and Tissue Donation Procurement Organization here. She joined UW in March of 2020, but she's no stranger to the University of Wisconsin. She did her transplant surgery fellowship here, and she has held transplant surgery position and was chief medical officer of the Organ Procurement Organization in Northern California and Western Nevada. We're delighted that she's here, and Dr. Neidlinger, we look forward to your presentation.
Okay, great. Thanks, Dixon. Can everyone hear okay? Sounds good. So thanks for the opportunity to present today. This news headline was March 11th, so it seems like quite a long time ago, but this is when COVID was declared a pandemic. And looking at this slide, it's kind of amazing to see the headline said 31 deaths in the country. And of course, now we're at almost 140,000. So a lot has changed since then. Next slide, Amanda. So on that day, in the beginning of March of this year, the nation had just been maintaining a pretty dramatic record pace of organ recovery. So 2019 was a record year for recovery of deceased organ donors, and the nation was recovering more than 250 donors a week up until that announcement about the pandemic. And you can see that this abruptly dropped here on the left. That very week when the pandemic was announced, it just about dropped in half the number of deceased donors that were recovered. And over the next couple of months, it gradually started to increase again, but we really have seen a couple months of dramatic decreased deceased donor activity. And in the center, the Great Lakes region shows a pretty similar pattern. On the right is the data from our own organ and tissue donation. And you see we even had a couple of weeks with 1 or 0 donors, which was unusually low for us. So next slide, back one, I think, is the organs transplanted from deceased donors, and it's a very similar picture. So we were transplanting 700 to 800 organs a week pretty consistently for the first couple months of 2020, with an abrupt drop again to about half of that volume as centers recognize some of the risks of which you'll hear more about on this webinar. So you see again, the Great Lakes in the middle depicts a very similar picture, and as does our local data. So as you all know in this call, that by mid to late March, most Americans were advised to shelter in place and to socially isolate. And there are quite a few publications from April and May of this year that really demonstrate that during this time, almost everybody who was seeking medical attention were people with COVID. So people with acute coronary syndromes and traumatic injuries and stroke admissions, the types of referrals that we often would receive as organ donors, were down across the country. And you see this New York Times headline on the upper right that pretty much says, where have all the heart attacks gone? And except for treating people with COVID, most hospitals were eerily quiet. And along that that same time frame, we saw a decline in our organ donor referrals. As you see in the graph here, we got down to only 135 referrals in April. It does seem, as you see, to have rebounded quickly and pretty vigorously. So next, how are organ procurement organizations screening the referrals that we get? This top box shows the epidemiologic screening that we're doing. Every donor, the family is undergoing a series of systemic questions that across the nation are universal, and they're being asked about potential COVID contacts, any confirmed diagnoses, recent travel, local COVID transmission rates are also evaluated. And anybody with known positive COVID is excluded as being a deceased organ and tissue donor. We also ask these clinical questions you see in the bottom box here regarding symptoms. And early in the pandemic, very early, we were not doing universal PCR testing, but we have been doing universal deceased donor PCR testing across the nation up since about the middle to late March of this year of 2020. So next slide. As we make offers to centers, just so keep in mind all the offers the centers are getting from deceased donors are from donors who've now tested COVID negative. So the centers are then charged with sort of making a risk-benefit decision based on a multitude of factors that you'll hear more about in this webinar. But some of those factors include the epidemiologic risk factors and where the donor is. So for instance, the New York City OPO was still recovering donors in March and April, but even with a negative COVID test, they really were virtually unable to place organs from many of the deceased donors in New York City. And Canada was also not accepting organs at all from the United States during the vast part of the epidemic. And the incubation period is another consideration to think about. So we're testing donors within 3 days of the deceased donor recovery. The logistics of sort of daily testing precludes us from being able to do that. So there's always the consideration of the incubation period as a risk. And another factor that we've been considering and talking about as a community is whether or not the virus spreads. We know it's a respiratory virus, but does it also spread into the organs and tissues that we would be recovering and transplanting? So we do consider organ donors who have other respiratory viruses such as influenza or H1N1. But for COVID, these are some of the questions that we've been asking across the nation. So to answer that, an early study came out of the epicenter in China and described 41 patients who were known to have COVID. Of course, all of them had fever and cough, but in that study, only about 15% of them had the virus also detectable in their blood. Next. So other publications also looking to try to answer these questions. The one on the top looked at more than 1,000 tissue specimens from 200 patients who had COVID. And as you can see, about 30% of them had the virus seen in the GI tract, as evidenced by stool. In that study, very few of them had virus in the blood or in the urine. But in a potentially conflicting study here on the bottom, this one in New England Journal looked at 22 patients who not only had COVID, but died of COVID. And that study found virus in many tissues beyond just the lungs. So 60% of those patients had virus in the kidneys and in the heart. And on the right, the graphic you see here, each gray box indicates that the virus was found in yet another tissue. So this needs to be considered as we're thinking about deceased donors who had been exposed to COVID, is whether or not the virus is spreading to these other tissues that we would consider transplanting and offering out in the future. So next slide, how are we doing? As a nation, there's actually been no published cases of any donor-derived COVID as of the 9th of July. This week's AJT included 2 opinion pieces. It was a bit of a debate about the future of COVID positive organ donors. And this first group advocated to consider COVID positive donors only under extreme circumstances. So in doing so, they cited that there actually have been 2 reports of living donors who tested positive for COVID either 1 or 2 days after donating. So of course, at the time of donation, these 2 were not known to have COVID, but they both subsequently the next day came back positive. One of them was a platelet donor and the other was a living liver donor. Both of their recipients were heavily immunosuppressed and did well without transmission. So this group advocated a fairly extreme position, admittedly, to consider COVID positive donors if they are asymptomatic, if the COVID is incidentally detected, if they have minimal or no systemic symptoms, and only consider these organs in patients with very high mortality risk. So, and hepatic liver donors or high status 1 heart recipients. But then again, this is again an opinion piece that was just published and is of course extreme and still under debate. So next slide, the counter argument, I would say paints a pretty clear picture of what's actually happening right now. So the current status of COVID positive donors is that across the country, we still believe there's a significant risk of bloodborne transmission. There are likely involved organs beyond just the lung. We really don't have effective therapy, and the risk to healthcare teams, recovery teams, and hospital teams is not insignificant, as is the utilization of hospital resources. So as of right now, we're currently not considering deceased donors who have any history of COVID or who have tested positive for COVID. And that's all I got. Thank you very much for your time.
Nicole, thank you for getting us off to a really great start. And I hope it's apparent to everybody how important it is to use the scientific information that is accumulating to be as safe and responsible as possible in allowing organ donation to proceed and to be able to safely transplant patients. And, we are very much involved in our safety here at the hospital, and we're going to continue the discussions now with a focus first on the abdominal and then the thoracic transplant patients. And our next speaker is Dr. Didier Mandelbrot. He's a professor of medicine in the Division of Nephrology in the Department of Medicine. He serves as the medical director of the UW Health Kidney and Pancreas Transplant Programs. He has clinical interests in the large practice of transplant nephrology and with a focus on living donation for kidney transplantation. Dr. Mandelbrot, we look forward to your presentation.
Thank you, Dixon. So yeah, I'm going to focus on abdominal transplants as well as living donation. And I'm going to start just sort of an overview of all transplants. And I think you just already saw a similar curve in terms of what's been going on in the United States over the last number of months. You can see that overall the number of transplants performed up until March was on the order of 800. And it dipped down. It didn't disappear completely in April, but it dipped down to about half. But by the end of May, and especially by June, the overall numbers have close to recovered. Next. So I think a lot of this information won't be surprising in terms of why there was such a decline in the transplant numbers. A lot of the concerns were that we in Wisconsin would have a similar experience to what we saw, happen in Wuhan, China, and then in Italy, and then in New York City, that there'd be a surge, and the hospitals would be overwhelmed. Regular floor beds, ICUs, operating rooms would all be full of COVID patients, and that there'd be no space for transplant patients. So that was a major factor. And then there were a number of factors related to the concerns that the transplant recipients might get the COVID virus. So either from the transplanted organ or in the hospital. And especially of concern was that transplant patients might get the viral infection after the transplant, when the fact that they'd be on immunosuppression, their immune system would be weaker, so that would increase their risk of complications and probably also increase the risk of their getting the virus. So this is sort of a big picture overview of some of the key factors. But again, if you look at that initial curve, the transplants did not disappear entirely. Even at the lowest point, there was a significant number that continued, and then there are a number of factors that contributed to that. The first is that many transplants are, of course, life-saving. And early on during the pandemic, CMS developed a tier as to which surgical procedures were considered to be the highest urgency and which were the lowest urgency. Many procedures were clearly elective and could be postponed, but transplant was actually put into the highest tier of highest urgency, the implication being that transplantation should generally continue. There are also factors relating to the fact we would not want to discard organs, put them in the garbage rather than use them to save or prolong lives with transplantation. There are other factors include the fact that there were, of course, there were and continue to be dramatic differences in COVID rates in different parts of the country. At the peak of the pandemic in April, New York City was hit hard. Now, in a lot of ways, the rates have flipped in different parts of the country. But clearly there's differences. So in parts of the country where rates are much lower, there's less of a barrier to continue transplantation. And then, of course, there are differences in risk tolerance, and both in terms of specific programs and specific patients and specific organs that come in terms of the risk benefit discussions. Next. So this breaks down the curve of recent months between living donor transplants and deceased donor transplants. And what you can see is that living donor transplants were reduced much more dramatically than deceased donor transplants. Really not completely to zero, but most of the way to zero for living donor transplants. Next. And so I wanted to just kind of give an overview for some of the reasons why there was such a much stronger push to make a pause for live donor kidney and live donor liver donation. So I think one of the main factors was the assumption that these transplants from live donors could simply be rescheduled in a few months. Many people thought that at the peak of the pandemic in March and April, that things would get a lot better in a few months and we could reschedule everything. I'll show some data, and you probably already know that it's not that simple in terms of the numbers, but we have found that by and large, we were able to simply delay live donor transplants for a few months. So that's why the numbers were so far down in April. There are some concerns also specific to live donation. So not only worried about recipients potentially developing COVID, but we were worried about potentially donors being in the hospital with many COVID patients and the donors developing a viral infection. And then the other, I think, important factor is that patients with end-stage kidney disease or end-stage liver disease who are relatively stable with intact immune systems, if the live donor transplant was proceeded with, then they would be converted to immunosuppressed transplant recipients, and again, therefore, a greater risk for COVID complications. The thought was that delaying that would be advantageous. There were some potential concerns with this widespread practice of delaying live donor transplants. There was and has panned out actually a small risk of live donors no longer being available to donate. There's various life situations, whether it's a teacher that only has time off in the summer, or various other life events that might come up. I actually just this morning heard about a live donor, actually it was a non-directed donor who lost their job, lost their health insurance, et cetera, and decided to hold off on donating. So there was a potential downside. Not everything could be simply delayed, but fortunately that's been relatively rare. The other ramification that we found just in terms of logistics is, not surprisingly, after putting a hold for a month or two on live donations, now we're trying to reschedule them. There's a backlog, and there's some competition with the backlog of all the other elective surgical procedures that are now being resumed. So there's some pressure for OR space, but I actually think that's been negotiated quite smoothly. For a while, the ORs were opened on Saturday, and various accommodations were made to prioritize and to be able to fit in all the procedures, including transplants that needed to be put in. Next. So again, familiar shape of curve of these curves, but I wanted to highlight these three curves specifically for kidney transplantation. The top curve, the orange one, is overall deceased donor transplants, and as I showed earlier, there was a decrease by maybe a third, and then a recovery by June in the numbers. The next line down is the gray line, and that's living donation. As I discussed, the living donation dropped further. The very lowest line is paired is a NKR, which is a National Paired Kidney Exchange organization. And you can see that those numbers dropped even further. So in April, a paired kidney exchange was basically completely stopped. So next slide. So just to talk a little bit about why these relative reduction in the numbers of deceased donation versus living donation versus kidney paired donation specifically. So as I said, live donation dropped more than deceased donation because of this assumption that living donors transplants could be delayed and simply rescheduled. There'd be no concerns about discarding organs. But the national paired kidney exchanges dropped really the most and essentially put a hold completely. Because there you rely on multiple live donor programs being active. You need to have both programs active. And while there were some programs that stayed active, they had a hard time finding a second or third program and an appropriate sort of paired exchange match for their live donors to be able to proceed. So again, that was almost essentially completely put a hold on paired exchanges. And just to show you the data for University of Wisconsin, kidney paired donation is really an important part of live donation for kidney transplantation. You can see at the top the number of the total KPD donors in 2017, 2018, and 2019 increased from in the order of maybe a quarter of our live donations to from 28 all the way to 65 last year. So which was about half of all our live donor kidney transplants. And then towards the bottom of the slide, you can see monthly, there was a complete halt in April on paired donation. But we're playing a lot of catch up. I actually just spoke to our paired donation coordinator this morning, and we're already up to 34 actually for the year, which is similar to last year. So hopefully we'll end up being able to catch up and have numbers that are close to what they were last year, if not quite as much. And then this slide is similar to probably the type of slides you've seen many times. I've actually probably looked at it. I found this is from the New York Times website. I found this very useful, and I've probably checked the daily numbers in Wisconsin every day since they started publishing this. It really has an important impact. As you know, so this curve does not look the way we would like. I mean, overall, the number of cases are going up. And this is in Wisconsin specifically. Obviously, it's not nearly as bad as a number of places in the country where the rise is exponential and dramatically higher. But there is a rise, and that means there's a little bit of a caveat about everything I say about we are opening up. Transplant is going smoothly and safely, but things may change in the future. The good news on this slide, though, is the second part on the bottom is the number of deaths. And unfortunately, in some parts of the country, those big rises in cases have been followed, typically 2 or 3 weeks later by an increase in number of deaths. But fortunately, in Wisconsin, you can see that at least at this point, the number of deaths in recent weeks has, first of all, been very low throughout the state, and if anything, going down. And you can see there's actually a number of days there in early July and late June where there were no deaths at all in Wisconsin. Presumably this is, sorry, same slide. This has to do with a lot of the newer cases being younger, healthier people. So less likely to get bad complications, less likely to be hospitalized, and less likely to perish. and also presumably reflects some improvements in management of these patients as we've gotten more experience. Next slide. So overall, some of the factors why we think it's safe to proceed and reassuring factors. The case numbers and especially the deaths in Dane and surrounding counties. So I just showed you for Wisconsin, but particularly in Dane County are relatively low. Unfortunately, they are rising some, but they're much lower than, for example, in the Milwaukee area. Again, fortunately, the number of hospitalizations at UW hospitals has continued to be relatively low. We get a daily update as to how many inpatients we have. And it's really very consistently been less than 10 inpatients out of the whole, UW 600 plus beds. And then there are the sort of usual precautions that have been implemented. Careful screening at the entrance. All staff, all visitors get the questions and temperature checks. Everybody wears a mask in the hospital. Every inpatient is screened for COVID. So ongoing precautions to reduce the concerns about COVID being spread in the hospital. Next. And then specifically to avoid COVID post-transplant, in the previous talk sort of mentioned some of these factors, but careful screening of the donors. Generally, no COVID positive living or deceased donors are used. As Dr. Niedlinger alluded to, there are some controversies. There are some people suggesting that maybe they should be considered, but at this point, we certainly have not at UW. Recipients are also carefully screened. As I mentioned, there's this concern of immunosuppressing someone who might be viremic. And it's actually induction immunosuppression, which means the immunosuppression at the time of surgery, which is much stronger. So it would be particularly of concern. And then the factors that are important for everybody, the social distancing and masks. Next. So early on, we were fortunate there was this guidance that was published. If you look at the very top of this slide, this paper was received March 17. This reflects the fact that this sort of advice on successfully navigating a pandemic was very much influenced by the international experience. And we have continued to use it and continued to use it to help guide us in what we were telling sort of the hospital, what we're doing in terms of reduction of activity. On the next slide, I'm not going to go through this whole paper, but this is just to show sort of one example of what this paper had. It was sort of different categories of percent reduction in transplant activity. This just shows the 25%, but there's sort of more details at a 50%, 75%, and complete 100% reduction in transplant activity. And if you look over on the right column, for example, if you're planning a 25% reduction in transplant activity, under kidney transplant, there'd be no living donor activity, but deceased donor activity would be allowed. Similar guidance for the liver transplant. The heart would continue normal activity, lung normal activity. Kidney, pancreas, there's also this sort of difference between simultaneous kidney and pancreas activity would continue as allowed, but isolated pancreas transplantation not allowed. So you can see that there was some sort of national guidance that I think we generally followed and found useful. Next. So one point to make specific to kidney transplantation is to remember that even though there's risks, and there were risks of proceeding with the transplant, the alternative for most patients who get a kidney transplant is dialysis. And we know that even though some patients are able to do home dialysis, most dialysis in America at least is performed in dialysis centers. And in those centers, social distancing is difficult. So there was really concerns about increased risk of getting COVID in the dialysis centers. And of course, there is a history of dialysis centers having been the site of outbreaks of a variety of other infections, hepatitis and others. So that this factor clearly weighed into the risk-benefit discussions and why, especially deceased donor transplantation, kidney transplantation, proceeded with only minor reductions. And of course, as I mentioned earlier, the importance of avoiding wasting organs, since we know there's already such a severe shortage of organs to transplant. Next. And then specifically in terms of resuming evaluations, so to get the pipeline of living donor transplants moving, you need to resume living donor evaluations. There were some specific issues that we addressed there. We've both in transplant and throughout the hospital started using a lot more video for many of the visits with patients. This is to protect both the potential live donors and staff. Preoperative testing, of course, is standard. There's a COVID PCR that's performed on everybody. We did explore for a while the new serological tests that had come out, the IgM and the IgG. We actually found that those false positives with those serologies were so high. And in fact, our first two patients that we tested this way were both false positives, that we no longer use the serology at all in our algorithms for donors or recipients. And then we took some additional precautions when patients were flying in to donate. We instituted a default of a 7-day quarantine and did an extra PCR to increase the sensitivity of picking up COVID, just to make sure if they're either flying or had other high-risk exposures. Next. In terms of pancreas, I sort of alluded to most of this already. The risk-benefit discussions, isolated pancreas transplants were felt to be less critical. Insulin is an alternative, although there are exceptions where a pancreas alone transplant could be considered life-saving. But this was basically put on hold. Simultaneous kidney pancreas transplants were continued, similar to kidneys. And at this point, pancreas transplant is fully resumed. Next. And then in terms of liver transplantation, there are many similar considerations, but it is a life-saving organ. That's the major difference. There's also sort of a hierarchy. The transplantation of higher MELD patients clearly continued unabated even during the time of peak concern. Some of the lower MELD patients were less urgent and were less likely to be transplanted, which of course is the case anyhow. They'd be lower on the list. You can see in terms of the volume over the course of the last few months, even in April, the volume of liver transplantation did not come down as much. Again, presumably because it's a life-saving organ. Next. Just a few words about outcomes. There was, basically, clearly transplant patients are at high risk for bad outcomes, along with other comorbidities such as being older and diabetic. There has been this hypothesis that's been discussed. I did want to mention the idea that immunosuppression might actually be protective for transplant patients. We know that cytokine storm is associated with a lot of the pulmonary decompensation. I think it's fair to say there's really no evidence for this. There's some controversy as to whether transplant patients do much worse or maybe just only a little bit worse than the general population. But clearly being transplanted is not protective from the complications of COVID. Next. And I will wrap up this, just a couple of examples of some of the national contributions at UW. This is my colleagues in the nephrology division and published actually 3 papers that have already appeared and one that's being reviewed. We've been quite active at looking at different aspects of kidney transplantation and COVID. And we've also participated in a national registry and been contributing patients, well, actually about to start contributing patients to that registry, so we can hopefully get more information about how to manage this virus in transplant patients in particular. I went over a little bit, but thank you for your attention.
Didier, thank you very much for a well-organized and comprehensive presentation. We have well over 100 attendees currently on the webinar, and I'm sure some of you have some questions that have come to mind, and hopefully at the end of our conference here, we'll be able to answer your questions, and you can enter those questions in our chat function. And we have many expert individuals that will provide great answers to your questions, including our next speaker, Dr. Malcolm DeCamp. He is professor of surgery and medicine. He is the chair of the Division of Cardiothoracic Surgery in the Department of Surgery at UW. He holds the Craig Kent Surgical Chair in Strategic Leadership and his clinical practice is devoted to surgical interventions for advanced lung disease, including lung transplantation. Dr. Camp, we're delighted you are here to present.
Thanks, Dixon. It's a pleasure to be here, and thanks, Mandy, for keeping me on time. Wanted to talk a little bit about heart and lung transplantation during the pandemic, and I really appreciate Nicole and DDA laying the groundwork, and I'll try not to be repetitive. This schema was just published recently in the journal Heart and Lung Transplantation to look at the interplay between thoracic transplantation and how COVID has impacted us. In the solid line, you can see what we all experienced, the anticipation with the continuous updates of what's going on around the world, then the period of active management as there was a surge in COVID patients. And then unfortunately, some of our colleagues nationally and internationally, especially in Italy and New York, come to mind that their health systems completely got overwhelmed. And the hospital's capacity to deal with just the COVID patients outstripped their ability to do almost everything else. And then period of recovery. And, this is oversimplified or set some sort of new normal smoldering rate. And then the dotted lines represent a variety of responses. And I highlighted the dotted curve C, which more approximates what happened in the whole field of transplantation here at University of Wisconsin. A would be a little bit of overreaction. B would be the response that was forced by us on top of centers that were completely overwhelmed, and we were somewhere in the middle. And so that sort of correlates with what my colleagues have already told you, and I'll move on and talk about some details of heart and lung transplantation now. Next slide depicts sort of curves that are familiar by now. This is the national data for both heart on the left and lung transplantation by week on the right nationally. And similar to, say, deceased donor kidney and liver, we saw about a 50% reduction across the country in heart transplantation, and not surprisingly, a much deeper decline in the number of lung transplants, since our organ was disproportionately affected by the actual pandemic, which loves to localize in the lungs. Next. And if you look at the number of heart transplants being done around the country, you can see that 2020 was setting up to be another record year, with transplants exceeding the volumes in 2019, leading into the pandemic, and then the decline in March and April, and recovery in May, and back now in June, with the data from June showing that, again, we're back on a record level of heart transplantation in the United States. From our better understanding of how to manage through the pandemic. Next. So here at UW, we mirrored the national experience. Things declined, especially by the end of February and March, though there was a steady state at about half the typical volume, and that is now recovered in May, and the data was incomplete in June. But we've had quite a bit of activity in the heart transplant program just in the last 3 weeks. Next. So what did we learn, and how do we keep our patients safe? On the donor side, we became more and more comfortable that nasopharyngeal swab PCRs were adequate, and we've had no donor transmitted disease in our experience. On the recipient side, of course, we maintained masks and social distancing, especially while people are on the list. And we leveraged as best we could telehealth to stay in touch with our patients, because they, and like all patients, didn't really want to come to the hospital unless they had to. All of our recipients were swabbed on admission. This was an interesting experience for us, where the turnaround time was a couple of days, and then a day, and then 8 hours, and then we finally got access to some rapid testing, and it made the timing of some of the transplants challenging for our teams. Of course, our patients in the hospital were cohorted away from the COVID patients, both the actual documented infected patients and patients under investigation. And we did not modify our immune suppression, even for the highly sensitized patients who received quite a bit of immunosuppression. And we're very fortunate there's been no documented in-hospital transmission of disease for some of these patients, for any of these patients. We learned early that we had to be very cognizant of the resource requirements as we navigated the pandemic. We were in constant contact with leadership, making sure that we had adequate PPE, not just for the surgical team, but our anesthesiologists who were at the beginning of the pandemic feeling like they were quite on the firing line. Our perfusionists, nurses, and the whole critical care team. Heart transplant can be a little intensive in terms of its requirements from the blood bank, so that became something that we had to check each and every time we wanted to continue the program, and of course the availability of our critical care beds. We had a tiered plan to deal with COVID, and fortunately we didn't ever get beyond 2 COVID units with a plan to get up to a total of 5, which is part of why we could continue to be active in this field. And then to keep the pipeline open, we really tried to leverage telehealth so that patients, as they were referred, weren't just put on hold, and we didn't create a long list of folks to get back to at the end of the pandemic, which I'm glad now, because the end's not quite in sight. And I think that's been one of the benefits in a variety of aspects of medicine, is leveraging telehealth for both the safety of our patients as well as ourselves. Next. One of the side benefits that we've experienced in our heart transplant program, because we've been able to continue working through the pandemic, is our median days to transplant have gone down considerably. You can see in 6-month aliquots, first half of 2019, our average days waiting on the list for 51 down to 22 in the second half of 2019. And in the last 6 months, which includes the pandemic, our median days to transplant's only 11. Next. So let's talk about lung for a minute. Nationally in lung, you can see again, we were experiencing a record level of transplants performed in the United States that obviously took a dive during the peak months of COVID, and really has not recovered like the other organs that we talked about today, like the heart, liver, kidney experience. I think, again, that reflects substantial residual concern about the lungs' pivotal role in the disease process of COVID. And as we'll talk about some of the other perhaps donor evaluation things that we'll talk about in a few minutes. Next. Mandy, you want to move on? Thanks. So consistent with those national numbers, we actually came to a screeching halt in April, did no transplants. Those 4 in March were in the first 2 weeks of March. And the volume only picked up towards the end of May, but it's continuing to move back up towards what we hope will allow us to catch up with our heart colleagues. We have a friendly competition in the CT division. And I always espouse the benefit of operating on a paired organ. So we can get a twofer out of this. Next. Some of the specific lessons around lung that we learned is that early on there was quite a bit of concern, both locally, nationally, and internationally, about the nasopharyngeal swabs and PCR adequate to make us comfortable to use these organs. And there was a number of folks around the world that were advocating for lower airway samples from either the trachea or bronchoalveolar lavage. As the PCR, we became more and more comfortable with the PCR test and its exquisite sensitivity. I think we've become more comfortable with this. We also found out that it is very hard to standardize the PCR evaluation of these samples that are obtained from the lower airways. The other problem around the country was there was inconsistent ways that the samples were processed. Some were processed in the institution where the donor was, some were sent out. So it became quite a barrier early on in transplantation. I must say in the last month, it's become much more consistent and across a variety of donor facilities. We still are facing some OPOs that refuse to perform bronchoscopy on their brain dead donors, which limits our ability to evaluate those donors, especially when they're quite a distance away, as we manage the risk reward decision about whether to mobilize a team and send them a great distance for that. We continue to use the epidemiologic data to evaluate COVID prevalence at the donor location, both total and in real time. And we appreciate that those models are continuing to be readily accessible. But despite all this, there's been no documentation of donor transmitted SARS-CoV-2, both here at UW and then frankly around the country as far as I'm aware. On the recipient side, we have been doing the same things that our CART colleagues do with masking, social distancing, with reinforcement on the list. And since we can't bring these patients in frequently for visits, we continue to leverage telehealth for frequent follow-ups. A challenge in our patients waiting for transplantation is that we typically mandate attendance to pulmonary rehab. That most of those rehab centers were closed because of social distancing concerns. And so that has been a challenge for us to keep in touch with our patients and get them on their treadmills or keep them as active as possible. They all get swabbed on admission, and we've had no asymptomatic positive swabs, so we've not had to cancel any transplants for that reason. They're cohorted away from the COVID patients, and again, we've used standard immunosuppression with no in-hospital transmission. We did have one false positive patient several weeks after transplant that got us quite anxious for a few days till we found out that that whole batch that had been run were falsely reported as positive. The resource situations are very similar to our heart colleagues. And then for our candidate referrals, we continue to try to leverage telehealth because there's great concern in the community still amongst our end-stage lung disease patients about coming to the hospital. They still feel that is an excessive risk. So we're trying to re-engineer the evaluation process and figure out what things we can accomplish remotely and what things absolutely mandate a visit in person. And I know each of the organ transplant teams, and we have our daily calls, are working through this algorithm to figure out how to minimize the number of face-to-face visits that we need, but ensure that we're doing adequate evaluations. Next. So unlike the heart program, especially because of a month-and-a-half hiatus where we did no transplants, we saw our days waiting creep up from less than 30 days as our median wait time last year to a little up to 40, but that's still quite a bit better than some of our peer institutions, both in this UNOS region and around the country. So there's been a lot of press about the few transplants done by colleagues of mine at the Northwestern, where both Dixon and I came from. The first patient is pictured in a much healthier state on the left. It's a young woman who contracted COVID in March and was managed on ECMO for 2.5 months until she cleared her virus by PCR, and at that point was clearly going to be ECMO dependent, with the only choices being transplantation or a terminal wean. The middle picture is a photograph of her actual explanted COVID-infected lung, and it's a very unique pathology. But by the time that this occurred, she'd really experienced the ravages not only of COVID, but multiple nosocomial pneumonias and pretty much a destroyed lung. Very challenging operation, but it's also led to some interesting understanding about what the PCR really detects. It detects, obviously, it's very sensitive and detects fragments of the viral gene, RNA. But later on in the course of the disease, it appears that some of the positives may not represent active viral disease and just fragments of RNA. So we look forward to other tests being evolved over time so we understand who's actively infected. They've gone on to perform a second double lung transplant, this one on a 60-year-old patient who's also on ECMO for 100 days. The difference between the two is this ECMO patient was allowed to be was allowed to be awake and was able to rehab so that they weren't dealing with the same amount of deconditioning that leads to a very protracted recovery. So this is not for everyone. It does generate a lot of phone calls. I try to refer those phone calls back to Chicago for the time being because it's a very resource intensive undertaking, but it's a natural extension, I think, of understanding the disease better and how we can better take care of our patients. I would bring everyone's attention to this paper that was just came out this month in the Journal of Heart and Lung Transplantation that creates this ethical framework regarding how we evaluate our patients and decide who should be operated on. And I think the last slide is just an algorithm that balances the urgency of the patients that we're evaluating in a normal environment, and then in various constraints as we deal with COVID potentially resurging, where we might be only doing the highest urgency transplants during a severe surge, or conversely looking at transplants that consume a lower amount of resources, for example, not weeks and months of ECMO and things like that would position the patient to be in the hospital for a long time, or more hopefully a balanced way of looking at this risk reduction. If we get where I'm afraid we're all going to go is to this low, steady state amount of COVID in our environment. Next. How we've done this, I think, has really been based on constant and frequent communication. Good communication builds trust, which in turn fosters better communication. We've had daily transplant leadership huddles for now 3 or 4 months. They've sort of been embedded in our day-to-day life. And it gives us a chance for all the different program leaders of all the different organs to discuss local and regional and national concerns, and then feed that up to the hospital incident command, where we are empowered by them to continue to move forward with transplant. The last slide is just sort of how it felt for the last few months, where we were the small person on the right trying to partner with our hospital incident command, where it was a bit of a black box some days about when we were going to get permission to move forward. But it's been a very positive experience. I think we've all learned a lot, and positions us to continue to push forward until we have a reliable vaccine or ability to deal with COVID in our environment. So thanks everybody for your attention.
Thanks, Mac, for putting together a really fine and crisp presentation. Let's continue now with our fourth presentation, and this one will be by Dr. Janina Smith. She is an associate professor in the Division of Infectious Disease in the Department of Medicine. She's the medical director of the Transplant Infectious Disease Program at UW Hospital and Clinic. She also directs the Infectious Disease Fellowship in the Department of Medicine, and her clinical expertise are in infections and recipients of solid organ transplants and other immune compromised disorders. Dr. Smith, thank you for being with us, and we look forward to your presentation.
Thank you so much for asking me. So today I'm going to talk about some of the new frontiers in COVID, including testing, going over rapid and point of care testing, PCR testing, and serologic tests, talking a little bit about COVID symptoms to see and whether that's any different in our transplant population, and finally a word, I think, of what we're all hoping for about vaccines. So this schematic, I think, is extremely helpful when thinking about COVID testing, because it tells us when we expect different types of tests to be positive, both nucleic acid-based testing and serologic testing over time. Now, there's a lot of question about the endpoints of some of these tests and when they might be seen. And I would also have you note on the lower part of the schematic, you'll see symptoms that we expect to see in that time frame, including the incubation periods. Next. So first, I'm going to start with point of care testing, because I think this is what we're all looking forward to in terms of care acutely of patients. So what do we mean when we say point of care testing? Well, point of care testing means it can be done where the care is delivered and does not require that you use a send out laboratory. Pros of point of care testing is ideally they should be very fast, anywhere from a 5 to a 45-minute turnaround time. And they should be easy, so they can be done in labs that don't have specialized expertise, such as push button technology, which reduces stress also on the microbiology lab. So point of care testing doesn't mean a specific type of test. Point of care testing can be nucleic acid amplification tests. They may be antigen-based tests or serologic tests. But for COVID, so far, our point of care testing is largely nucleic acid amplification tests. This here on the right is the now very famous Avid COVID-19 ID Now mobile molecular point of care device. It's the most famous because it had its own press conference in the Rose Garden. The pro of this test is it's extremely rapid. It can be done in around 5 minutes. However, some of the cons of this test is it can only process one sample at a time. So for a lot of our uses, it would not be very useful. And unfortunately, the biggest con is in a number of trials since its release, we found that it misses as many as 50% of positive cases. Next slide. Because of this, in mid-May, the Food and Drug Administration issued a rare public warning about the Abbott Laboratories COVID-19 tests related to these adverse event reports that showed us the sensitivity and specificity, the sensitivity specifically was not very good for this test. That led to a larger point of care platform, the Cepheid Gene Expert Express, and that's actually what we're using at UW Hospital. This test is larger and it can't be done in small clinics and is based more in hospitals and large medical centers. But this has an extremely high throughput, much higher than other mobile platforms, and yet it still is able to return results in less than an hour. It is still just a machine, so the components are all self-contained. And so it does have kind of point and click technology for fewer laboratory resources. Some of the uses of this type of testing is to test healthcare providers and symptomatic patients, which enables maintenance of our workforce. So our employee health program here at UW has done an amazing number of tests with very rapid turnaround, and that's allowed our providers to have rapid return to work when their testing returns negative. This allows us to reduce PPE use with patients, and also provides us rapid diagnosis for critically ill patients. So while there was about a 50% sensitivity with the Abbott testing, the Cepheid Gene Expert is more sensitive, closer to 98%. Now, a problem that we've had at UW as nationwide is that the reagents for this test sometimes are in short supply. And so when tests are able to have a longer turnaround time, we're still trying to be judicious in our use of this resource because reagents have been an issue throughout the pandemic. Next slide. I think this quote really sums up my thoughts about testing. And Wyatt Earp, the very famous gunslinger, once said, "Fast is fine, but accuracy is final." And I think we really do want tests that accurately represent COVID infection as we move forward. Next slide. So when we're looking at accuracy, there really is no substitute for real-time PCR testing. There's a depiction on the right of sample collection, which leads to RNA extraction, reverse transcription, and then DNA polymerase processing, which releases a dye in positive cases. And it's tiny, but on the bottom, you can see what happens in a positive test, and you'll see something called CT and that cycle time. And that's something that you'll see when we discuss testing. And I think it is part of the wave of the future. So our sensitivity of our real-time PCR here at UW uses this number that's called limit of detection. And what that limit of detection is how much genetic material has to be present for the test to trip positive. And I've spoken personally with our microbiology lab director, and our limit of detection is as low, we think, as a single virion. That's been really helpful because it really reduces the false negative rate that we've seen in other testing types because it's extremely sensitive. However, that also leads to some of the problems that we've discussed is that when our transplant patients are positive, we have had patients persistently positive with nucleic acid testing. We have a patient who tested positive in March who is still positive and has had 6 positive tests. We don't know then that that's replicative virus or a virus that's capable of causing infection. And the cycle time may tell us some information about that. However, I think the next phase in coronavirus testing will be a viral load, and that may give us some more information. And the cycle time is a surrogate for that at this time. This type of testing is extraordinarily specific as well, with 99% or more specificity. Next slide. So what happens? How do we get false negative tests with these advanced RT-PCRs? So first, and I think importantly, the sample was not collected properly. And so I myself have performed this test, and it hurts your heart because patients tell you that it's like a brain biopsy. And when I was taught to do it, it said if the patient doesn't cry, you probably didn't do it right. So it really does require an aggressive sampling of the nasopharynx, which involves insertion of the swab quite deep. After we've collected the swab, provided it was collected properly, if the sample isn't stored properly, it can still lead to viral degradation and false negative testing, especially when there wasn't a large amount of virus present. The virus may not be found at the site selected, and I think my prior speakers have alluded to the concern that it appears SARS starts as an upper respiratory tract infection, but can progress to more of a lower respiratory tract infection. And so with less sensitive tests, we worry that a nasopharyngeal swab no longer reflects what is actually in the lungs. And there are reported cases of lower respiratory samples being positive when the upper respiratory samples are negative. And again, we simply don't know how to interpret that. Is it just that there's no longer replicated virus hanging around in the lungs, in the necrotic tissue, or why are the samples persistently positive? And I think we're actively trying to research that question, actually as part of a UW program to look at the meaning of persistent positive tests in transplant. It's also possible that the viral level was actually on its way down or on its way up. And so that refers to the window period in which someone should be positive but hasn't tested positive yet, or no longer is infectious but is still positive. This table I included because it's a summary of the prevalence and pretest probability for different specimen types. And I think one of our hopes someday, because it is quite an invasive procedure to give a good nasopharyngeal swab, is to come up with swab types that perhaps are even patient administered. And for example, for influenza, we found that those swab types actually can be quite effective. So you may have seen pictures of people in airports in Asia where they're getting an oral swab, kind of like you think of for genetic testing. And those swabs may be positive in the setting of COVID, but when you compare them to the nasopharyngeal swab, the sensitivity is simply not as good. Interestingly, saliva tests are better. And mid-turbinate swabs are actually also excellent. Next slide. So Dr. DeCamp recently referred to a patient who had a false positive nucleic acid test and what happened there. What can happen is this test is so sensitive that a single virion can tip positive. And so contamination of reagents or the machinery or the gloves of our microbiology techs can contaminate a whole batch of sample. And all of it needs to be cleaned and repeated. There can also be sample mislabeling that can produce a false positive. But otherwise, these tests are extraordinarily specific, and they don't pick up the RNA if it's not there. That stands in stark contrast to the COVID serologic tests. So COVID serologic tests, much like other serologic tests, are looking at IgM that we see in acute infection, and IgG, the memory type of antibody after infection. In COVID, we know that both generally appear around the same time, usually within 2 weeks of infection. I think this is important, and I want you to keep it in your mind as to why I'm not a huge advocate for use of IgM testing. Next slide. So again, this is a perspective, that same slide we looked at earlier, and I'd like to focus on the blue line of IgM and then the purple line of IgG. So you can see that they appear around the same time. In fact, the antinuclear protein IgG appears first. Next slide. So counter to the tight control the FDA had of nucleic acid testing, there were not a lot of controls on release of serologic testing to the market. And as expected, then there was a huge flood of hundreds of tests actually that hit the market claiming to be serologic assays for COVID prior infection. The goal of these high quality assays is a sensitivity greater than 95% and a specificity superior or equal to 98%. It is true that many different platforms can be considered for these type of serologic tests. What we're hoping for at some point is one of these high quality assays that's a lateral flow assay. And for those of you who don't do lab testing all the time, the most famous lateral flow assay that you can do at home is a pregnancy test. So at some point we may get something as simple where you spit into a test on a stick and you'll see whether you had antibodies. Other types of tests that tend to be a little more sensitive that we do in the lab and that are being developed is ELISAs and chemoluminescent assays for serology. Next slide. However, as one might expect from what we've laid out, very soon after serologic tests rolled out in the United States, there are increasing news reports of flawed antibody tests because of the lack of FDA review. Next slide. So speaking about serologic tests in general, IgM of all serologic tests is more likely to have false positives. In the specific case of coronavirus infection, they may show reactivation due to infection with other coronaviruses, like the kind that cause the common cold, and they may actually cross-react to other pathogens. Additionally, we know with serologic tests, persons with inflammation, for example, autoimmune disease, very often make antibodies that will become positive on serologic testing. There haven't been cases in COVID yet, but I can only imagine that there will be. So why would a serologic test be false negative? It's possible that not enough time has passed since the time of infection to have made memory antibody to be tested. It's possible that too much time has passed. And so I think there was a rather frightening study that came out of England just this week that suggested that 2 months after a COVID infection, even patients who had had neutralizing antibody had lost it in some cases. And so we simply don't know the durability of the antibody response to this infection. I will say that with SARS type 1, there was long-lasting antibody protection. And so this slide summarizes what I've mentioned. So to know that someone's current symptoms are due to COVID, the really best type of tests are nucleic acid-based tests, and I would advocate for the gene expert test or RT-PCRs as the most sensitive and specific. IgM really doesn't help you much if you look, and because of its false positive rate, I don't advocate. But using IgG may tell you about prior infection or the development of antibodies. But I think it's very important to note that does not connote protection from infection. We don't yet know that the antibodies we're detecting in serologic tests provide immunity, and if so, if it does, how long that immunity may last. Next slide. So getting at the specific pros and cons, nucleic acid-based tests are very specific. They're very sensitive. They're positive earlier, and you can screen large populations. And I think one of the things that we that will very much be impacted about the number of patients who are persons in your community that are infected is pooled samples. And I do foresee a time when we may show up for work, spit in a cup, and that they run 500 pooled samples, and that they'll trip if one of you is positive, and then specifically say, okay, this batch of people needs to wait until we've more specifically noted who has COVID. Some of the cons is that in most cases, if you go back to that last slide, some of the cons is it in most cases does require an NP swab at this time. It seems to not pick up cases of non-respiratory infection. And this part is something I want you to note. So patients, for example, with COVID toes almost never have positive PCRs, and only a small fraction have IgG antibody. However, we've been able to show that the virus is actually present when you biopsy the lesion. So it is clearly caused by COVID, but it's a hole in our testing. Similarly, it's been noted that patients with GI illness as the primary features of their COVID infection are less likely to have a positive nasopharyngeal swab, and yet they appear to have even a worse prognosis than patients with a primary respiratory manifestation. As we talked about, it stays positive after someone is not contagious any longer, and some patients have been reported to have really long positivity, and they do not tell who is immune. Similarly, the serologic tests or a simple blood test or lateral flow assay, they can be used in patients who did not get testing right away or who primarily don't have respiratory symptoms, and they can tell us perhaps how many people in a population have had COVID, but they may not be very sensitive nor specific, and they also cannot tell who is immune. Next slide. So moving forward to COVID symptoms, this schematic shows that COVID appears to impact many levels, many organs in the body. And I really think of it as an endothelial infection because it really explains best its manifestations. We can go to the next slide. These are the type of symptoms we expect both in emergency warning signs, and the CDC, I should note, added a number of these symptoms, including the diarrhea and fatigue just recently. Next slide. These are some pictures of some of the other manifestations, including the COVID toes and fingers, a libido type reaction that's not unexpected given the endothelial involvement, as well as an urticaria. Kawasaki-like inflammatory syndromes have been noted in children, including much older children, including young adults recently, and concerns about thrombosis, including PE, MI, CVAs, DVTs, and I just was just published priapism, have been noted even late after COVID, probably because of the endothelial involvement. And just yesterday, they noted a pathological series that suggests orchitis and potential impact on fertility in patients who have had, male patients who have had COVID infection. Additionally, Science published a series showing young adults who developed new type 1 diabetes. It does not appear that COVID manifests much differently in transplant. This is from the New England Journal series, from the largest series here in New York. The presenting symptoms are mostly fever and respiratory symptoms, but a significant number of patients do have a GI presentation, including diarrhea. Because of that, the there's testing algorithm that's put out by the Infectious Disease Society of America. And because we're getting late on time, I'm gonna just hit the high points, which is that we do recommend testing of all symptomatic patients, of all, you can go to the next slide, of all exposed patients. And I think on the last slide here, the really pertinent one that I think not all centers are doing is a recommendation to test patients prior to immune suppression. And I think the transplant community is doing a much better job than other groups that use immunosuppression, for example, TNF inhibitors for rheumatologic diseases. Okay, finally, I'm happy to talk about something hopeful moving forward for the future. So the New York Times has this wonderful vaccine tracker. Just this week, there's been very exciting news on the vaccine front. I think it's something we're all very hopeful for. 2 different vaccine types. So a vectored a simian adenovirus vectored vaccine, that's the Oxford group, studied at the Jenner Institute, just published their phase 2, and they're moving to phase 3 with excellent vaccine response and neutralizing response. And then the Pfizer vaccine as well as the Moderna vaccine are mRNA vaccines. And both of those have had strongly encouraging phase 2 trials and are moving in July into phase 3 trials with the hope of mass production of vaccine. So I remain hopeful that with advances in testing and vaccination, we will get through this pandemic sooner than we fear. And so I'm very open to questions. Thank you for allowing me to speak to you today.
Thank you, Janina, for another outstanding presentation. I hope that everybody has found this to increase your knowledge and awareness of COVID-19 and how transplantation is able to be carefully and safely performed. I don't think that we really have much time for questions, being that we're kind of late in the hour. And I think I'd like to throw it back over to Mandy if you have any wrap-up comments to make. But again, my appreciation to all the speakers for preparing so well and providing such fantastic information. Mandy?
Yeah, thank you, Dr. Kaufman. And thank you to everyone for joining us today. I'd like to let you know the session has been recorded and will be available for viewing at uwhealth.org/transplant in the near future. And for all the attendees, you will be receiving an email after the session. And if you do have additional questions for our speakers, you can direct those to me via the directions in that email, and we can address those. So thank you, everyone, for your participation today. And that concludes our session. Thank you.
Thanks, Mandy.
Thanks, Mandy. Thank you, everyone.